In this video, we'll be covering the shoulder and the scapular region. The shoulder girdle, also called the pectoral girdle, is a mobile bony structure that allows for a variety of different movements. The two bones of the shoulder girdle include the clavicle and the scapula. As you can visualize in the upper right image, the clavicle articulates with the manubrium of the sternum at the sternoclavicular joint. This joint is strongly reinforced by the sternoclavicular and the costoclavicular ligaments. In fact, this joint is so strong that whenever forceful downward traction is placed on the lateral clavicle, the clavicle tends to break and fracture instead of dislocating the sternoclavicular joint. Laterally, the clavicle articulates with the acromion at the acromioclavicular joint. This is abbreviated oftentimes the AC joint. And as a reminder, the clavicle is exclusively responsible for connecting the shoulder girdle to the axial skeleton. In conjunction with the scapula and the lateral border of the first rib, the clavicle helps to form an opening called the cervical axillary canal, which is a passageway for the neurovascular bundle that supplies the upper limb. This canal is outlined here in orange and is shaded by this orange triangular shaped region. Again, vessels and nerves course through this canal in order to enter the upper limb. The movements of the clavicle that are permitted at the sternoclavicular joint include protraction and retraction. About 25 degrees of movement are permitted in both the forward and the backward direction. So when you're on the dance floor shimmying, you are protracting and retracting your clavicles. Slight depression or a dipping of the clavicle is allowed up to about a negative 10 degrees. The most substantial movement of the clavicle occurs during elevation of the shoulder, in which the clavicle can be raised to about 40 degrees above the resting plane. The key take-home message here is that the relatively subtle movements of the clavicle are necessary in order to enable increased range of motion for the upper extremity as a whole. Regarding the osteology of the clavicle, its shape resembles that of a crankshaft, which you would see on old antique cars in order to crank over the engine. By way of bony landmarks, I only want you to know that the smaller end of the clavicle is the sternal end, and the larger, flatter, broader end of the clavicle is the acromial end, which would connect with the acromion to form the acromioclavicular joint. The clavicle shown in the image is therefore a right clavicle. Unlike the clavicle, the osteology of the scapula is much more important, so let's take the time to walk through this. In general, the scapula is a very flat bone with 3 angles, 3 borders, and 3 fossae. The superior angle of the scapula has been presented previously as being the site of attachment for the levator scapulae muscle, which functions to elevate the scapula in concert with the trapezius muscle. The relatively vertical edge of the scapula that runs from the superior angle down to the inferior angle is referred to as the medial border. It's sometimes called the vertebral border because this border is positioned against the vertebral column. As you know from a previous video, the medial border is the site of attachment for the rhomboid muscles, which are responsible for retracting the scapulae. On the posterior surface of the inferior angle of the scapula, there is a roughened area which is the site of attachment for the teres major muscle. And the area next to it, shaded in green along the lateral border, is the site of attachment for the teres minor muscle. We'll look at the details of these muscles in just a moment. The lateral border of the scapula, also known as the axillary border, terminates as a shallow depression called the glenoid cavity or glenoid fossa, which articulates with the head of the humerus. The sloped edge of the scapula between the superior angle and the glenoid fossa represents the superior border of the scapula. Along the superior border, near the base of the coracoid process, there is a characteristic notch called the suprascapular notch. And there is a ligament that arches over this notch, transforming it into the suprascapular foramen. This ligament is known as the superior transverse scapular ligament. During dissection, this will be an important landmark. On the posterior surface of the scapula, there are two fossae that are separated by the spine of the scapula, which is shown here. The depression above the spine is referred to as the supraspinous fossa, and within this concavity sits the supraspinatus muscle, one of the four muscles of the rotator cuff. The infraspinous fossa is the depression below the spine of the scapula. The muscle that occupies this space is the infraspinatus muscle, another of the rotator cuff muscles. Between the spine of the scapula and the glenoid cavity is a notch which connects the supraspinous fossa with the infraspinous fossa. The notch is the spinoglenoid notch and is the route by which a neurovascular bundle runs from the supraspinous fossa down to the infraspinous fossa. From this lateral view, you can better appreciate the very shallow glenoid cavity. The two tiny bumps above and below the glenoid cavity are referred to as the supraglenoid tubercle and the infraglenoid tubercle. The supraglenoid tubercle is the site of attachment for the long head of the biceps muscle. Whereas the long head of the triceps attaches to the infraglenoid tubercle. The third fossa is positioned on the anterior surface of the scapula, and it's known as the subscapular fossa. The muscle that consumes this fossa is referred to as the subscapularis muscle, another of the rotator cuff muscles. It is also worth mentioning that the serratus anterior muscle makes its attachment on the anterior surface along the medial vertebral border of the scapula, shown here by light blue. The anterior facing bony knob-like projection is referred to as the coracoid process. The word coracoid means beak. The coracoid is the site of attachment for three different muscles: the pectoralis minor, the coracobrachialis muscle, and the short head of the biceps. There are also two ligaments that attach here: the coracoacromial ligament and the coracoclavicular ligament. The scapula itself is capable of considerable movement along the posterior thoracic wall. When we shrug our shoulders, we are demonstrating scapular elevation, which is achieved by both the trapezius muscle, specifically its upper fibers, and the levator scapulae muscle. Gravity is mostly responsible for depressing the scapula, but it receives some help from the lower fibers of the trapezius muscle. And to retract the scapulae, which means we're bringing them closer to the midline of the body, closer to the spine, requires help from both the middle fibers of the trapezius muscle as well as the rhomboids. To protract your scapula means you're moving it towards the mid-axillary line, and that requires contraction of the serratus anterior muscle, shown here. Again, this muscle is slipping underneath the scapula to attach to the anterior surface along its medial border. When thinking about the rotation of the scapula, you'll want to use either the glenoid cavity or the acromion as your point of reference. If the glenoid cavity tilts upward, then upward rotation has occurred thanks to the upper fibers of the trapezius muscle and thanks to the lower fibers of the serratus anterior muscle. Downward rotation of the scapula is mainly accomplished through gravity with assistance from the latissimus dorsi muscle and the rhomboids, and to a lesser extent, the levator scapulae. The shoulder girdle receives the proximal humerus. Specifically, the head of the humerus, shown here in purple, articulates with the glenoid cavity at the glenohumeral joint. The articular surface of the humeral head is lined by hyaline cartilage. The obliquely oriented anatomical neck, labeled here by the letter A, provides an attachment point for the fibrous joint capsule, whereas the surgical neck, labeled here S, and indicated by the hashed line, is the narrow part of the shaft immediately distal to the head and the tuberosities. The surgical neck is clinically important because it is a common site for fractures of the humerus. Not only that, but there is an artery-nerve pair that is positioned at the surgical neck. The nerve represented in gold is the axillary nerve, and the artery represented in red is the posterior circumflex humeral artery. As you can imagine, a fracture at the surgical neck can compromise this nerve-artery pair, which could lead to muscular deficits. Between the anatomical and the surgical neck are two large tuberosities for the insertion of the rotator cuff muscles. We'll refer to these as the greater and lesser tuberosities of the humerus. The lesser tubercle, shown here in blue, is the insertion point for the subscapularis muscle. The greater tubercle and its respective facets receive the remaining three rotator cuff muscles. Positioned between the greater and lesser tuberosities is a deep groove that goes by several names. This is referred to as the intertubercular sulcus, the intertubercular groove, or the bicipital groove. Seated within this sulcus is the tendon for the long head of the biceps muscle that inserts onto the supraglenoid tubercle of the scapula. A ligament called the transverse humeral ligament spans between these tuberosities in order to keep the tendon seated within the groove. The medial and lateral lips of the bicipital groove are formed by the crests that extend distally from the tuberosities. The lateral lip or crest is the point of insertion for the pectoralis major muscle. Along the floor of the bicipital groove is the insertion point for the latissimus dorsi muscle. And the teres major muscle attaches to the medial lip of the sulcus. About halfway down along the lateral aspect of the shaft of the humerus is an elongated raised bump referred to as the deltoid tuberosity. This is where the deltoid muscle will attach. From the posterior view, we can appreciate the attachment points for the other rotator cuff muscles inserting onto the three facets of the greater tuberosity. If you remember the acronym SIT from top to bottom, this will help you to remember the attachments of the supraspinatus, infraspinatus, and teres minor muscles, respectively. The superior facet of the greater tuberosity receives the supraspinatus muscle, the middle facet, the infraspinatus muscle, and the inferior facet, the teres minor muscle. S-I-T, SIT. Also on the posterior aspect of the humerus is the spiral groove, also referred to as the radial groove. This groove transmits the radial nerve, shown here in gold, and the deep brachial artery, shown here in red, which is also referred to as the profunda brachii. As you can imagine, a mid-shaft fracture of the humerus places the radial nerve and the deep brachial artery at risk for injury because of their close proximity to the shaft of the humerus. And while we're discussing the radial groove, I'll also point out that this groove separates the origins of the medial head of the triceps muscle from the lateral head of the triceps brachii muscle. Here's what the articulation of the proximal humerus and scapula looks like at the glenohumeral joint. In the joint video, we'll talk at length about the glenohumeral joint. For now, simply appreciate that this joint is stabilized and reinforced by the joint capsule, a series of ligaments, and is also reinforced by the rotator cuff muscles and their respective tendons. We'll return to the specifics of this joint in the next video. External to the joint capsule are the subacromial and subdeltoid bursae that are positioned beneath the acromion and the deltoid muscle respectively. Here's the subacromial bursa, and here's the subdeltoid bursa. Notice how the subacromial bursa not only underlies the acromion, but it also underlies the coracoacromial ligament. By definition, a bursa is a thin-walled sac filled with synovial fluid that acts as a cushion between muscles and joints and facilitates smooth gliding between structures, thereby reducing friction. The subacromial bursa therefore reduces friction between the acromion and the supraspinatus muscle and tendon. The subdeltoid bursa reduces friction as the deltoid muscle acts on the humerus. In the MRI, notice how the subdeltoid bursa is continuous with the subacromial bursa to form one large bursa. Also notice in this MRI, we can visualize the acromion, shown here. The clavicle is here, specifically the lateral clavicle. This is the supraspinatus muscle and tendon, and here is the deltoid muscle. This small arrow happens to be pointing out a small glenoid labrum tear. We'll revisit that again in the joint video. The deltoid muscle received its name due to its shape of the inverted Greek letter delta. The deltoid muscle arises from the spine of the scapula, the acromion, and the lateral one-third of the clavicle. It attaches distally to the deltoid tuberosity of the humerus. The deltoid has three component parts, which can act independently or can act in concert with one another. The posterior, also called spinal part of the deltoid, assists in extension of the arm. The anterior or clavicular part of the deltoid assists in flexion of the arm. So when you're walking down the street, the swinging motion of your arms is accomplished by both the clavicular and spinal portions of the deltoid. The lateral portion of the deltoid comes from the acromion, shown here. When all three parts of the deltoid contract simultaneously, the arm is abducted. In other words, it is moved away from the body. Note, however, that the deltoid muscle is very lousy at initiating abduction of the arm. This is because when the arm is fully adducted against the side of the body, the muscle pulls directly upward on the humerus, and so it has no mechanical advantage. As such, during the first 10 to 15 degrees of abduction, the deltoid receives assistance from the supraspinatus muscle. After about 15 degrees, the deltoid takes over and is fully effective at that point. Another function of the deltoid is that it prevents inferior dislocation of the humeral head when an individual is carrying a heavy load. For example, it helps to prevent the humerus from slipping inferiorly when you're carrying heavy baggage through the airport. Innervation to the deltoid muscle is through the axillary nerve. The axillary nerve accompanies the posterior circumflex humeral artery on its course to innervate the deltoid muscle. The artery and nerve wrap around the surgical neck of the humerus as they emerge through a space called the quadrangular space. Here's the axillary nerve, accompanied by the posterior circumflex humeral artery as they emerge through the quadrangular space. The quadrangular space is so named because of its four boundaries. Above, it is bound by the teres minor muscle. Medially, it is bound by the long head of the triceps. Laterally, it is bound by the surgical neck of the humerus, and inferiorly, it is bound by the teres major muscle. Both fractures of the surgical neck of the humerus, as well as shoulder dislocations, can compromise the axillary nerve and the posterior circumflex humeral artery. In the image on the left, I've placed a blue oval on the patient's arm. This oval represents the deltoid skin patch, also known as the regimental badge, because of its location where you would find a badge on a soldier's arm. The deltoid skin patch is supplied by a branch of the axillary nerve, specifically called the superior lateral cutaneous nerve of the arm. When this patient in the image walked into the exam room, he presented with paresthesia, which is numbness and tingling at the deltoid skin patch. And if you look closely, He has atrophy of the deltoid muscle. Notice how the shoulder has lost its nice rounded contour. Together, these two signs are enough to diagnose this patient with an axillary nerve palsy. As you can imagine, upon physical examination, the patient was unable to abduct his right arm beyond 15 degrees. Because again, the axillary nerve innervates the deltoid muscle, which in this case is severely atrophied. There are two other spaces I want to point out. The first space is the triangular interval. This space is an inverted triangle bound by the teres major above, and to the sides is bound by the long head of the triceps muscle and the shaft of the humerus. This interval creates a passageway for the radial nerve and the deep brachial artery as they enter and pass along the spiral groove. The last space of lesser significance is referred to as the triangular space. Its boundaries include the teres major, the teres minor, and the long head of the triceps brachii muscle. This space allows for communication between the axilla and the posterior scapula. Coursing through this small space is the circumflex scapular artery, which we'll talk more about in another video. Let's review the cutaneous innervation of the shoulder. Most of the shoulder is supplied by the axillary nerve, specifically from the branch of the superior lateral cutaneous nerve. Again, this area here represents the deltoid skin patch, which is innervated by C5 specifically. In other words, the C5 dermatome. The upper parts of the shoulder, specifically over the acromion and the clavicle, are innervated by what we call supraclavicular nerves. We'll learn more about these nerves in a different video. For today, the axillary nerve is the nerve of most importance. In addition to the deltoid acting on the humerus, there are also four muscles of the rotator cuff that act on the humerus as well. The rotator cuff consists of the supraspinatus muscle, the infraspinatus, the teres minor, and the subscapularis muscle. The supraspinatus muscle sits within the supraspinous fossa as shown here. This muscle, as already alluded to, assists the deltoid muscle by initiating abduction for the first 10 to 15 degrees. Again, this muscle initiates arm abduction. And it accomplishes this task by having its tendon pull on the greater tuberosity. As the tendon of the supraspinatus muscle inserts onto the greater tuberosity, its fibers blend with and reinforce the fibrous joint capsule of the glenohumeral joint. From this coronal view, I'll remind you that the subacromial and the subdeltoid bursae overlie the tendon of the supraspinatus muscle. In a condition called calcific supraspinatus tendinitis, a calcification forms in the tendon of the supraspinatus muscle, thereby causing inflammation of the tendon and potentially causing inflammation of the subacromial bursa, which is referred to as subacromial bursitis. As you can imagine, this results in a painful shoulder, which is aggravated by arm abduction. If there has been forceful trauma to the shoulder, to the extent that the supraspinatus tendon pulls away from the greater tuberosity and takes a chunk of bone with it, this is called an avulsion fracture of the supraspinatus tendon. A patient with this type of avulsion fracture would have great difficulty in initiating arm abduction. Recognize that the supraspinatus tendon can also become impinged underneath the acromion, resulting in shoulder pain. As a fun fact, shoulder pain is the third most common cause of musculoskeletal disability following lower back pain and cervical pain. The infraspinatus muscle, shown here, occupies the infraspinous fossa, and it too attaches to the greater tuberosity of the humerus, right here through its tendon. Because of its orientation, this muscle is a very powerful lateral rotator of the arm. Both the supraspinatus and infraspinatus muscles are innervated and supplied by the suprascapular nerve and artery. The suprascapular nerve originates from the upper trunk of the brachial plexus, which receives contributions from spinal cord levels C5 and C6. You'll appreciate the significance of these cord levels when we get to the brachial plexus. The suprascapular artery will arise from the thyrocervical trunk in the root of the neck. Notice there is a slight difference in the course of the artery versus the course of the nerve. The nerve runs underneath the superior transverse scapular ligament through the suprascapular foramen. However, the artery runs above the ligament. One way to remember this is that the Army goes over the bridge while the Navy goes under. Army representing the artery, of course, and Navy representing the nerve. To reach the infraspinatus muscle, the artery and nerve course around the spinoglenoid notch to access the infraspinous fossa. Clinically speaking, it is possible for the superior transverse scapular ligament to ossify. If this happens, the suprascapular nerve can become entrapped, leading to downstream functional deficits. This entrapment would compromise the supraspinatus muscle, making it difficult for a patient to initiate abduction, and it would also compromise the infraspinatus muscle, leading to severe weakness upon lateral rotation of the humerus. Here are some students from the medical class of 2020 on Halloween demonstrating the relationship of the suprascapular artery and nerve to the superior transverse scapular ligament, which acts as that bridge over top of the suprascapular foramen. Army over, Navy under. The smaller teres minor muscle is also a lateral rotator of the arm. However, it receives its innervation from the axillary nerve. Recall the axillary nerve is the same nerve that innervates the deltoid muscle. So in the condition we just discussed, in which the suprascapular nerve became entrapped within the suprascapular foramen, lateral rotation of the arm was not entirely lost. Instead of full-blown paralysis upon lateral rotation, there is weakness because the axillary nerve is still intact, and therefore the teres minor muscle has full function of laterally rotating the arm. But recognize the size of this muscle is much smaller than the infraspinatus muscle. Therefore, there will be weakness upon lateral rotation. And the last of the rotator cuff muscles is the subscapularis muscle, shown here in the subscapular fossa. The subscapularis muscle is the only muscle attaching to the lesser tuberosity of the humerus. Because the subscapularis muscle attaches to the anterior surface of the humerus, it will be responsible for medially rotating the arm. It will also assist with adduction of a raised arm, which would bring that arm back down to the body. This muscle is dually innervated by both the upper and the lower subscapular nerves, which come from the posterior cord of the brachial plexus. Again, more on this when we get to the brachial plexus. Realize that the glenohumeral joint is reinforced not only by ligaments, but also by the rotator cuff muscles and their respective tendons. The tonic contractions of the infraspinatus and subscapularis muscles complement one another to keep the humeral head centered and in contact with the glenoid cavity. The lower image is a reminder that the deltoid muscle works to keep the humeral head elevated and prevents it from slipping inferiorly from the glenoid cavity. The teres major is the inferiormost muscle of the posterior scapula that attaches from the roughened area of the inferior angle to the medial lip of the intertubercular sulcus. Notice how it crosses the lower boundary of the axilla and sneaks to the anterior side of the proximal humerus. As such, this muscle is a medial rotator of the arm. In addition, the teres major can help to adduct an outstretched arm, as well as extend a flexed arm. The teres major is in close proximity to the subscapularis muscle. As such, it will share innervation with the subscapularis through the lower subscapular nerve. As you've learned already, the teres major is a landmark for all three spaces of the scapular region, including the quadrangular space, the triangular interval, and the triangular space. The last muscle associated with the scapula is the serratus anterior muscle. This muscle attaches to the anterior medial border of the scapula and produces movements at the physiologic scapulothoracic joint. This muscle is named because its causal attachments resemble the serrated edge of a carpenter's saw. Functionally, the serratus anterior muscle protracts the scapula, moving it closer to the mid-axillary line. The lower fibers of this muscle will also assist in upward rotation of the scapula. And lastly, the serratus anterior helps to affix the scapula against the posterior thoracic wall so that arm flexion against resistance can occur. Picture yourself doing a push-up. Without the serratus anterior muscle affixing the scapula against the posterior thoracic wall, there is no stability and really nothing to push against while you're performing the push-up. If the serratus anterior loses its ability to fully contract, it presents as a winged scapula. When a patient pushes against a wall, for example, the scapula on the affected side flails posteriorly and protrudes like a wing. This type of presentation suggests that the long thoracic nerve, which originates from C5 through C7 and innervates the serratus anterior muscle, has been compromised in some way. During surgical procedures such as mastectomies, lymphadenectomies, and axillary dissections, the long thoracic nerve is vulnerable to injury because for much of its course it lies on the superficial surface of the serratus anterior muscle as shown here. Breast surgeons are always on the lookout for the long thoracic nerve so that they can isolate and spare this nerve during surgery. For those of you who are boxing enthusiasts, the serratus anterior is the boxer's muscle. This is because it allows a boxer to get his or her right hook around. Why do boxers keep their elbows tight against their sides? Well, to protect the long thoracic nerve, of course. A strong jab to the lateral thoracic wall could not only break a rib, but would be enough to cause a compression lesion of the long thoracic nerve, which would temporarily paralyze the serratus anterior muscle, thereby preventing the opponent from being able to protract the scapula in order to throw a punch. See, anatomy is useful for so much more than clinical medicine. Because some individuals prefer learning from a table, I've included this summary table here. In total, there are 11 different muscles that act on the glenohumeral joint to accomplish the 7 movements permitted at the joint. Let this slide serve as a reference slide for you to revisit as you see fit. The only thing I would like to point out is that all the muscles of the rotator cuff, which again includes the subscapularis, infraspinatus, teres minor, and supraspinatus, are all innervated by nerves that originate from the cord levels C5 through C6. Once we get to the brachial plexus, this will have even more meaning. This concludes the lecture on the shoulder and scapular region. As always, happy studying!